of FAP have a multiple fundy gland polyps?
Gastric glands, gastric polyps.
Sorry, sir.
What was the histology of gastric polyps?
It's fundy gland polyps, sir.
So, and what was the side wing examination done for the ampulla?
Sir, on forward wing endoscopy, there was no any lesion in the duodenum. We have done a side wing endoscopy.
Carry on, please.
We might expect adenomatous polyps in the stomach. Reduce yourself. We might expect adenomatous polyps in the stomach. These gastric polyps may not be adenomatous, and fundy gland polyps, in fact, are commoner than the adenomatous polyps. So, in the same way, in this case, we have found out that this patient is having fundy gland polyps rather than adenomatous polyps. And endoscopy into the duodenum did not show any polyps. Papilla area was well seen by forward wing endoscopy also. So that's why we have not gone ahead with the side wing endoscopy. There are, fortunately, in this patient, as Dipen has said, that there are no duodenal polyps. Only gastric polyps are there, and they are too not adenomatous. That is the finding in this patient.
Thank you, Dr. Ravishankar. Thank you.
Maybe go ahead, sir. Go ahead.
You can carry on, Dipen.
Yes, sir. So it's FAP is the most common and best characterized adenomatous polyposis syndrome, which have autosomal dominant inheritance. It have 80 to 100% of penetrance. Prevalence is 1 in 5 to 7,000 people. Responsible gene is APC, which was located in the long arm of chromosome 5 on 21 or 22 position. It's a tumor suppressor gene. Mutated APC is inherited as a germline mutation. It's a regulator of chronic epithelial cells. APC protein has a beta-catenin binding portion. So disruption of the beta-catenin results in chromosomal instability. So clinical feature of FAP, most probably they will be asymptomatic when you screen for the high-risk individuals. Patient may present with bleeding PR, diarrhea, or abdominal pain, and patient have large size polyp or develop colorectal carcinoma. Diagnosis is made by the sigmoidoscopy, which shows process polyps in the rectum and colon. However, colonoscopy is preferred to looking for full phenotypic expressions and exclusion of proximal CRCs. Phenotypic diagnosis, we require number of more than 100 polyps, and histopathology, it should be adenoma. For confirmation of diagnosis, we require genetic testing. It should be positive APC gene test. Time for polyp to cancer development is 10 to 15 years. On colonoscopy, we may found up to 10,000 adenoma polyps. Number and size of the polyp is correspond to the latent period between onset of clinical feature and time of detection. Polyp tend to be more in number in symptomatic person as compared to asymptomatic patient. Mutation of the APC gene between codon 1250 to 464 have a profuse polyp as compared to mutation in other parts of the gene. Polyp are usually small in size, they are less than 1 centimeter, and they are sessile. All type of adenoma like tubular, tubulovillous, or villous adenoma can be seen. So adenomas usually develop at the age of 10 to 12 years. Average age for diagnosis of FAP is 36 years. For CRC is 39 years, and death is at the age of 42 years. CRC is inevitable in FAP patient after 10 to 15 years if the colon is left intact. However, 25% of the FAP patient may have CRC at the time of colectomy. FAP may have more synchronous CRCs, like almost 48%, out of which 41 may have synchronous and 7 may have metachronous CRCs. For upper GI lesions, the most common is gastric polyp with a non-neoplastic fundy gland polyp, which can be seen in 88% of patients. They are mostly seen in first decade of life. They are small in size and they are sessile. However, dysplasia can be seen in 25 to 41% of patients. Gastric adenoma are uncommon, can be seen in 5%. They are mostly seen in antrum. Adenocarcinoma are very rarely seen, more in Japan as compared to Western population. Incidence of gastric cancer is 0.6 to 4.2%. Microcarcinoids may be found in the stomach. In duodenum, we may have found adenoma in more than 90% of patients. They are rarely seen before 30 years. They may sometimes involve the ampulla and obstruct the PD, which may lead to pancreatitis. 50 to 85% of patients may have adenomatous change of papilla of Vater. So risk of duodenal carcinoma is 4 to 12%. Basically, there's a Spiegelman classification for duodenal polyp, out of which stage 3 and stage 4 are more prone to develop adenocarcinoma, and stage 4 may require surgery. Small intestinal lesions, the jejunal adenoma can be seen in 45 to 75% of patients. Ileal adenoma can be seen in 10 to 20% of patients. However, malignant transformation is very rarely seen. Clinical vigilance is done by the capsule endoscopy, CT or MR enterography, or enteroscopy. Other extraintestinal manifestations like bone abnormalities like osteoma, ectostosis, or teeth abnormalities. In eye examination, we found a congenital hypertrophy of retinal pigment epithelium. In mesentery, we found desmoid tumor, soft tissue tumor like epidermoid cyst, lipoma, fibroma, neoplasm of the biliary tree, liver, in biliary tree, liver, and adrenal glands. In thyroid, we found papillary carcinoma of thyroid, which mostly seen in female. In very young children, we found hepatoblastoma and medulloblastoma in Turcotte syndrome. So, for genetic testing and counseling, it should be genetic testing is done by extracting DNA from leukocyte in the peripheral blood or from the buccal swabs. They recommend at the age of 10 to 12 years of age. Indication of genetic testing are patients who have more than 10 adenomas in single colonoscopy, or more than 20 adenomas in lifetime, or who have 10 adenomas with personal history of colorectal carcinoma. When patient phenotype suggests polyposis syndrome, but diagnosis was not certain, and when testing the asymptomatic relative of a known polyposis syndrome patient. 20% of PEP patients may have negative family history. Affected person should be tested first. Absence of mutation in the affected person means genetic testing would be negative in the family members. So treatment of PEP, surgery is a definitive option for chronic polyps. Recommended age is 10 to 25 years. Two type of surgery is the total colectomy with ileostomy or ileal pouch anastomosis. There is rectal sparing colectomy with ileorectal anastomosis. Indication of surgery, imaging indications are like suspected or documented colorectal carcinoma or who have significant symptoms. Early indication for early surgeries are polyp more than 10 mm size, polyp with high-grade dysplasia, or progressive increase in number of polyps. Relative indications are multiple adenoma more than 6 mm in size and multiple diminutive polyps. Surgeries, total colectomy with ileal pouch anastomosis, indicated when the rectal polyp is more than 20, total chronic adenoma is more than 1000, polyp is more than 1 centimeter in size, and polyp with high-grade dysplasia. However, women should be counseled about the decreased fertility after the surgery, so should be delayed surgery in female. Patient may have future development of adenoma on CRC over 10 years. Second surgery is rectal sparing colectomy with ileorectal anastomosis, indicated when the patient's rectum has a low polyp burden, less than 20 polyp in rectum, total chronic adenoma is less than 1000, and attenuated variant of PEP. Patient may have better quality of life with this surgery. However, the high risk of future development of colorectal carcinoma at the rate of 1% per year may require second surgery in the future. Patient should be counseling about that, and may go for polypectomy if size is more than 5 mm and done sigmoidoscopic surveillance at 3 to 6 months interval. Adverse effect of surgeries are diarrhea, nocturnal defecation, fecal incontinence, fecal urgency, sexual dysfunction, diet restriction in the form of low residue diet, and infertility. So chemo prevention, vitamin C, calcium, alpha tocopherol, and dietary fiber have modest effect. At present, they are not recommended. NSAIDs like Fulindec inhibit the COX cyclooxygenase activity and interfere with arachidonic acid metabolism. Is capable of restoring the deficient apoptosis in the colonocyte of PEP patient. Dose is 150 mg twice daily. In RCTs over 9 months, we have shown decrease the number of in 56% of patients, decrease the size of adenoma in 65% of patients. However, effects are reversible upon discontinuation of the medicine. The second NSAID is celecoxib. It may be given in the dose of 400 mg twice daily, which shows the 45% reduction in the number of colonic polyps, but may increase the cardiovascular risk. Third NSAID is aspirin, 600 mg per day. No much role, not that much role in chemo prevention. Next group is epidermal growth factor receptor inhibitor like erlotinib is given in dose of 75 milligram per day, which is usually erlotinib is combined with sulindac and given for 6 months. There is a 70% regression in the adenoma size. Chemoprevention in duodenum, NSAID alone is not effective, so we have to give erlotinib and sulindac combined. So for approach to a polyposis patient, generally depending on the number of the polyps, if there is more than 100 polyps, so it's most probably patient having a FAB, we should go for APC gene testing, and when it's turned out to be positive, the family member should be go for screening. If it's turned to be negative, we go for MYH gene testing, and if his gene is turned out to be positive, then his siblings and spouse should be screened for the mutation. For management purpose, if it is more than 100 polyps, patient should be go for the total proctocolectomy with eagle pouch anastomosis. Should we go for upper GI tract screening? If it is 10 to 100 polyposis, patient can be managed with colonoscopy and polypectomy if feasible. If it is not possible to manage with polypectomy, may go for colectomy. Patient should be have upper GI, should be scheduled for upper GI tract screening. So screening for FAP patient start at the age of 10 to 12 years. Sigmoidoscopy should be initially started and interval at the 1 to 2 year. After total colectomy with eagle pouch anastomosis, patient may have future risk for development of CRC. So we should do for pouch endoscopy and start at the age after 1 year of surgery, and interval is 1 to 2 years. If we found high grade dysplasia, it should be at the interval should be 6 months. After subtotal colectomy with ileorectal anastomosis, screening start after 6 months of surgery and surveillance interval 6 months to 1 year. Similarly, for upper GI lesion, we should start at the age of 125 years or before colectomy. And for duodenal lesion, we divide duodenal lesion by Spiegelman classification, and we do accordingly the staging of the polyps. For small bowel screening, done by capsule endoscopy or MR enterography, and should be done at the when the patient plan for surgery for duodenal polyps. My last slide, sir. This is the source of safe injure of ASG guideline and ACG guideline. Thank you. This is my last slide.
So can you unshare the slide so that we can have some discussion? Yes, Dr. Ravi Shankar, you asked questions, and there are 2 questions on the chat box also.
Yes, sir. I've seen a question. Chance of malignant transformation of fundic gland polyps greater than 1 centimeter in a person with FAP. I think these fundic gland polyps have a lesser incidence. I mean, malignancy is rare in these polyps, but some of these patients we have to be very careful because they rarely, sometimes adenomatous polyps can be there associated with this, and whatever we have taken out be a fundic gland polyp with less chance of malignancy, but associated if they are glands, adenomatous polyps, they stand a high risk. So we need to be vigilant. Maybe if we find in this patient, like this patient, we may not be going ahead and doing anything unusual, but we have to be vigilant and find if there is any polyp that grows out of proportion and has issues. Have another question. How do we ascertain the number of polyps? Counting 100 isn't easy. But once we look at the colon, it is all carpeted. Then once we focus the colonoscope and move it a few centimeters this side and that side, we can just understand that the polyps are too many. And carpeting, as in this patient, whatever Dipen has shown, he has shown a few polyps, but inside it was carpeted with polyps. More than thousands were there.
So, Dipen, your
2 questions we have across, sir.
So, Dipen, you talked about the classification for duodenal polyps. Can you further elaborate on that? That what is this grading about, and how does it affect the approach?
Sir, basically it includes four things: polyps number, size, histology. So we accordingly we give numbers, and we have 12 numbers, 12 points, and 0 to 4 is stage 1, 5 to 6 is stage 2, 7 to 8 is stage 3, and stage 4, 10 to 14 is stage 4. Sir. So as the stage increases, there is increased chance of developing malignancy. So, and we accordingly change our screening protocol, sir. So in stage 4 patient, there is 36% chance of developing a malignancy. So stage 4 patients should directly go for surgery, and stage 1 to 3 do screening accordingly.
So these surgeries will be primarily Whipple's procedure?
Sir, we said first to take the biopsy, and we invasive we go for Whipple surgery, so that is we can do pancreatic filtering surgery also. If showing more size, more higher dysplasia, then we may go for Whipple surgery.
So what should be the policy for gastric polyps? We should just, as Dr. Ravi Shankar said, that we should go on screening them, or do you think at some stage we have to plan gastrectomy also?
Sir,
And also a question from my side, I'm sorry for asking too many questions because there are hardly any questions from the DNB students. But then what is the actual role for chemoprevention you talked about? What are we preventing? Are we preventing the polyp from being formed? Are we preventing the polyps to be transformed into malignants?
we decrease the we try to decrease the number and size of the polyp. However, chemoprevention does not prevent development of carcinoma.
Okay, and is there any indication of doing a gastrectomy in patient with multiple adenomatous polypi?
Sorry, sir?
Is there indication for doing gastrectomy if there are multiple large gastric polypi?
Sir, it's depending on the histology and size. If it is having a high grade dysplasia and size is more than 1 centimeter, we can go for a gastrectomy.
So if there is no more question, should we go on to the second topic?
Sir, can I add one comment?
Rakesh, yes, Rakesh, most welcome.
Sir, regarding the fundic gland polyps, I just wanted to add one comment. As
Yes,
such,
sure.
yes, as such, fundic polyps are in patients of FFP, the fundic polyps in FFP patients, they have a tendency of getting into malignancy, and the chance is as high as 5 to 8%. The endoscopic features are 3. If there is a covalence of the polyps, or if the polyp is getting discoloration, or if there is a flattening of the fundic polyps, they are the markers of endoscopy to suspect that it might be going for a malignant transformation. I think that is one thing we can look at.
So the one more question before we go on to the second one, you did talk about rectum having less than 20 polypi. You try to preserve the rectum and you do an anastomosis. Now, so in that case, if there are a few polypi in the rectum, what will be the policy for following up if you are doing an ileorectal anastomosis? We can't hear you. You need to unmute yourself.
So at this stage, we go for screening sigmoidoscopy at 3 to 6 months interval. And if polyp size is more than 5 mm, we go for polypectomy and do screening at 3 to 6 months interval.
So are there situations where you have to go for the second surgery for the rectum?
Yes, sir.
I think this is not a very favorable situation, the ileorectal anastomosis, because there is always a risk of development of further polyps, and there the chemoprevention role comes. But I think in India we are not using too much of this chemoprevention, and when the polyps come, there should be a proper surveillance, and then polypectomies. But if the dysplasia develops, then we stand a risk as next to surgery. Again, the rectum has to be excised, and a second surgery would come. This can occur in about 30 to 40% of the patients if the patient survives for the next 2 to 3 decades. I think to overcome this problem, one needs to discuss with the patient and an initial surgery that includes a rectal resection and ileal pouch anastomosis. The problem with ileal pouch anastomosis is that there could be a little more complication rate compared to ileorectal anastomosis. And ileorectal anastomosis seems to be a reasonably straightforward surgery, but the problem is with the surveillance. The ileal pouch anastomosis may have some problem like infertility in the patients when the dissection is not very close to the rectum. And of course, this can be avoided by using laparoscopic methods and the robotic methods. But of course, these are the issues that are there with these two surgeries.
Okay, thank you. So should we, Rakesh, move on to the second case? I just want to know, the pain is a final year student? Which year are you?
Right. I couldn't get you, sir.
Student. Student.
There has been some disturbance.
Okay. I just want to know whether Deepan is a final year student or he is a second year student.
The final year student.
Okay, so you're going to appear for the exam in February. Is that
Okay,
okay?
sir.
Hitesh, click on no and share your
Let's
presentation.
go on. Let's go on.
Close this one. Dr. Hitesh, close this. You have already logged in. Just share your presentation.
Share your presentation.
Minimize this page.
This is not the. Okay, for your
Dr. Hitesh, click on your presentation.
Yes, sir. Sir.
Slideshow.
I can see the screen.
Yes.
Yeah, it's all right.
Yes, you may continue.
Good evening, sir. Am I audible, sir?
Yes, you are audible. Yes, you are audible.
I am very thankful to DNB and Mahesh Goenka, sir, for giving me this opportunity to present my topic for today's presentation, the case of IBD with pregnancy. It's a 26-year-old pregnant lady with 16 weeks of gestation, presented with chief complaints of bloody stool since last 4 to 6 weeks. Her stool frequency was 5 to 6 times, present both during day and night. It was loose with small stool volume. It was non-small smelling and not associated with excessive bloating or abdominal fullness, but was associated with urgency and tenesmus. It was not aggravated by diet or other factors. Blood present was on small quantity. It was mixed with stool and present most of the time. She was treated at her hometown by local practitioner, considering it as a hemorrhoid, as a possibility with local application, and was also given antibiotics along with some supportive treatment. But with that, there was only partial relief of her symptoms. So she came to our OPD with these complaints. On evaluation, there was no history of abdominal pain, no history of fever, no history of joint pain, rash, or any skin lesion. There was no history of jaundice, any radiation exposure in the past, no endoscopic procedure in the past, no history of constipation, no history of abdominal pain or perianal discharge. There is also no history of weight loss, decreased appetite, easy fatigability, or shortness of breath. Her past history, there is no history of similar complaints in the past. There is no history of tuberculosis or surgery. Family history, there is no history of similar complaints in any of the family members. Her personal history, not suggestive of addiction to alcohol or smoking. Her appetite was normal. Her obstetric history, she is gravida 1 L0A0 with 16 weeks of gestation. On examination, on general examination, she was conscious oriented in time, place, and person. She is afebrile with pulse of 94 per minute, regular, good volume, equal on both sides. His BP was 124/70 in right arm supine position. Her respiratory rate was 16 per minute. There is mild pallor, no icterus, clubbing cyanosis, lymphadenopathy, or pedal edema. There are no other signs of nutritional deficiency, no extraintestinal features of IBD, no signs of internal malignancy. Her systemic examination was within normal limits. Her per-rectal examination was also normal. So it's a case of chronic inflammatory diarrhea of large bowel origin. Most likely etiology is inflammatory disease, that is inflammatory bowel disease. Ulcerative colitis more than Crohn's disease. Second possibility is infectious diseases like invasive bacterial infection like Clostridium difficile, viral infection like CMV, or parasitic infection like strongyloidosis. Also, I will also keep the possibility of neoplastic. Her lab parameter shows anemia with HbO of 8.5 with thrombocytosis and mildly elevated CRP. A peripheral smear shows microcytic hypochromic anemia. Her LFT was normal with albumin slightly on the lower side, that is 3.5. RFT, electrolytes, and thyroid profile were normal. Ultrasound abdomen and viral screening ultrasound abdomen is normal, viral screening were negative. Her stool examination is negative for any OA cyst or parasites. We did her fecal calprotectin is elevated, that is 260 microgram per milligram. So we did her colonoscopy, which shows marked erythema, loss of vascular pattern, friability, and erosions. So it's extending up to descending colon. So we had it is a left-sided colitis, whether either infective or IBD. So after her biopsy reports, which shows there is transmucosal inflammation with cryptitis, crypt abscesses, and distortion of crypt architecture, along with mucin depletion. So our final diagnosis is a case of IBD with left-sided colitis of moderate severity. So again, back to our patient. She is a 16 weeks pregnant lady with IBD with left-sided colitis of moderate severity. So as per ECO guidelines, we started her on 5-ASA, 1.2 gram BD. Her entire pregnancy and postpartum course was uneventful. So as described in ECO guidelines, if patient has quiescent disease, we have to continue mesalamine on maintenance therapy. If patient has mild disease, we have to start on topical treatment and or oral mesalamine. For moderate colitis, we have to give topical plus oral mesalamine. But while in case of severe left-sided colitis, we have to start mesalamine plus steroids. We also have to ask the patient to get admitted. So now IBD and pregnancy. Effect of IBD on pregnancy. Patients with IBD, whether CD or UC, tend to have pregnancy outcomes worse than those women without IBD. Patients with IBD were more likely to have spontaneous abortions. They have eclampsia, preeclampsia, placenta previa, abruptio placentae, and there is prolonged premature rupture of membrane. Some studies have demonstrated that rate of fetal loss, preterm birth, and low birth weight are higher in patients who conceive while their IBD is active. The risk of giving birth to a child with congenital congenital anomaly among mothers with IBD is controversial. Now, what is the effect of pregnancy on IBD? In most female patients with IBD who conceive while their disease is in remission, the IBD tends to remain in remission throughout pregnancy and in postpartum period. That is seen in up to 80% of the female patients. While patients with UC who conceive while their disease is active, there is 45% chance the colitis will worsen. 25% chance the colitis continues to be active but stable, while in 30%, it may go into remission. Among patients with CD who conceive while their disease is active, the law of 1/3 is applicable. That is, about 1/3 of the patient will go into remission, 1/3 will have active disease, while 1/3 will have worsening of the disease. So before going into the medications that is used in pregnancy in IBD, I will just wash up through this FDA category. In category A drugs are control studies show no risk. Category B shows no evidence of risk in human. The chance of fetal harm is remote. In category C, the risk not excluded, but adequate studies are lacking. So chance of fetal harm, but benefits outweigh the risk. While in category D, there is obvious evidence of risk in the fetus. So potential benefit, if there is condition which definitely needs treatment, like active collagen, then only pregnant woman should start on that medication. Category X, these are contraindicated, absolute contraindicated in pregnancy. So drugs for IBD in pregnancy, category B, it includes sulfasalazine, mesalamine, except delayed release preparations, and anti-TNF agents like infliximab, adalimumab, certolizumab, or golimumab, and metronidazole. While category C includes delayed release mesalamine preparations, olsalazine, anti-integrin inhibitors like natalizumab, corticosteroids, ciprofloxacin, and rifaximin. Category D includes 6-mercaptopurine and azathioprine, while category X include methotrexate and thalidomide. So this is my last slide. The use of 5-ASA products is safe during pregnancy, despite their presence in cord blood. Although thiopurines are category D, it is recommended that thiopurine drugs to be continued in pregnancy with the goal of keeping mother's IBD under control. As per Pregnancy in IBD Neonatal Outcome Registry, confirm that the use of thiopurines does not lead to worse fetal outcome. Methotrexate is category X drug in pregnancy and is the only drug to be discontinued during pregnancy. Biologicals are considered as class B, as already mentioned. So, some physicians stop biologicals at 20 weeks of gestation to minimize the transfer of these drugs across the placenta. No live vaccination during first 6 months of the fetus to be given. So IBD medications are safe to take during the conception period and during pregnancy, except 2 medications, that is methotrexate and thalidomide. Thank you.
So Rakesh, there are a number of questions on the chat box. Can you ask? I think let Hitesh answer those questions.
Yes, sir, Bill. I'll try to back him up.
Yeah, sure. So can you read out these questions for Hitesh? Hitesh, can you stop sharing?
Hitesh, why did you come?
Yes, sir.
Yeah, Hitesh, why did you consider CMV colitis as one of your differential diagnoses? Why was CMV colitis considered as an initial differential diagnosis in your patient? Any specific reason?
She had She she had bloody diarrhea.
But you are not audible, Hitesh. Can you
She
make
had bloody diarrhea. Sir,
Dr. Hitesh, close your camera and then speak.
yeah. Hitesh, you are yeah. I think although CMB Hitesh, can you answer that?
Sir, I am audible, sir.
Yes, now you are audible.
Okay, sir. CMV patient has bloody diarrhea since last 4 to 6 weeks, and she has already started some antibiotic, and she received some antibiotic, but I don't know, sir, exactly why.
No, I mean to put it to the point. I mean the point here is that CMV colitis should be entertained only in patients whom you usually have already made diagnosis of IBD with UC. CMV colitis per se without a background IBD is very unusual. I think that's the point which Dr. Amit wanted to comment on. Okay, so CMV colitis is very much a differentials when you have a patient of known IBD with UC coming with flaring of the symptoms. Okay, so the next question is, what is the role of cyclosporine in a severe UC?
Sir, cyclosporine can be used as a rescue therapy in patients with acute severe colitis, sir. In that patient, if patients not.
So if you have a patient who has fulminant colitis, and once you have started the patient on IV steroid, by day 3, if you do not see any significant change in the patient's CRT, the option is to go for cyclosporine vis-a-vis biologicals.
Yes, sir.
Yeah. So the other question is that can colectomy be done safely in pregnancy, and what is the ideal time?
Sir, colectomy can be considered in pregnancy if it is a life-threatening situation. Otherwise, we have to continue. We have to continue her on medical therapy as much as possible.
Exactly. So whenever you have an acute severe colitis in pregnant lady, the priority is to the mother. So salvaging the mother, starting with IV steroids. If the patient is not responding, you can escalate, and probably colectomy can also be advised.
Yes.
The next question is, can steroid affect the fetal lung maturity? So how safe is steroid, and what should be the exact regimen? Can you answer that, Hitesh?
Sir, there are reports, sir. Steroid will have high dose of steroid will have minor orofacial malformations can be there, but that is like cleft lip they have mentioned, sir. Major abnormalities which steroids now not mentioned, sir. Only
yeah, but the important point here is that steroid to be used only if the patient has an active flare, and that is the time when the steroid comes into the picture. And definitely, if you are using the steroid in the last trimester of pregnancy, chances of affecting the fetal lung maturity is always a possibility. But again, here the mother health and clinical status takes the precedence. So if there is an active flare in IBD, you should probably use the steroid as a standard regimen as prescribed. And the next question is, what should be the lactation advice to patients with IBD? Lactation advice.
Patients with IBD on medication should continue to lactate the baby, sir. There are no contraindication for lactation if she is on medication.
Yeah, although breast milk, the PSS have been detected in low levels, but still there is no active contraindication against lactating the fetus. So the next question is, if this patient has not responded to PSA and topical therapy, what would have been your next management plan?
So I will go with step-up therapy, sir. If patients not responding to PSA, and I will go with oral steroids, sir. I will start him on prednisolone 40 milligram per day. I will see the response by 3 to 5 days.
So again, follow the echo guidelines. So if you feel that the patient of moderate IBD not responding, you can always escalate the therapy to oral steroid. So the next question is, in fetus, can it be caused by a biological safe? Are biological safe in pregnancy?
Yes. Yes, sir. Biologicals are safe in pregnancy. They are, as I already mentioned, they are category B drugs. So there are already studies are there, and it has mentioned there is no risk of major complications in fetus while taking biologicals during pregnancy.
So the point here I want to add to Hitesh is that most of the biologicals are molecules with heavy weight, and these molecules do not cross the placenta till 20 weeks of pregnancy. So I think biologicals can be safely given when the lady becomes 20 weeks pregnant. It is only after the 20th week that the biologicals start going across the placenta into the fetus blood. So the only word of caution you have to give to the pediatrician is that since the biologicals have entered the fetus blood, no active vaccination, live vaccine to be given for the first 6 months of the newborn's age. It's only after the first 6 months that you start giving the live vaccine. I think that is the important point to be remembered. Biologicals can be safely given, but 2 points. One, the pediatrician should be informed that the baby should not be given live vaccine for the first 6 months of their age. And the second important is that if the patient is on adalimumab or infliximab, try to time your dose in such a way that you are at least 2 to 3 weeks ahead of the EGD of the pregnant lady.
Yes, sir.
And why does ileostomy or the IPA pouch affects the fertility? So what's the theory behind that, Hitesh?
Sir, they have said that, sir, post IPPA, there are development of adhesions that will compress the fallopian tubes. So it is like a mechanical cause that leads to infertility in these patients.
It is not only, it is probably multifactorial. One of the major is adhesions, but also the pelvic nerves. The pelvic nerves are also affected. So even that leads to affecting the fertility in these women. The other question is, what's the role of topical steroids, where it stands?
So as per ECO guidelines, sir, in patients with moderate, like in patients with proctitis or left-sided colitis, where along with oral we have to give topical treatment. Their topical steroid can be used as an alternative to topical 5-ASA, sir.
So this is in moderate or severe left-sided?
Moderate, sir.
Okay. So I think we have come to the end of the queries in the chat box, sir. Goenka sir, anything from your end, sir? Sir, we have come to the end of the queries in the chat box, sir. Goenka sir, anything from your end?
I think both the presentations were very to the point, very neat presentation, and they were not confusing. So I must thank both the presenters as well as to the faculty, both Rakesh and Dr. Ravi, for a very good presentation. So I think we'll wind up now until there is any last minute comments, and we would also invite everybody next week, Monday, 6 p.m. again, and we'll stay back in Hyderabad. So the next presentation is from Nizam Institute, Hyderabad. And let's see what they are presenting. I don't have yet the information, but there'll be 2 presentations from the MBA students. Let me again reconfirm that there is no dependency in this. The compulsory, and if there are any objections from any Please let us know